Good afternoon, everyone. In the past 30 years, the landscape of office-based anesthesia has changed. And what we're going to share with you today is the issue of the complexity of patients and procedures that we're doing and the needs for an emergency preparedness. And also we'll share with you a little bit about anesthesia of the future and what we're doing with research. So I'm the Director of Research and Medical Education at Mass Eye and Ear. I'm the President-elect of SAMBA, and my interests are improving patient safety and ambulatory anesthesia and mentoring the next generation. My topic is going to be last. I'm going to talk about technology and AI in office-based anesthesia. But our first speaker is Niraja Rajan. She's a professor of anesthesiology and perioperative medicine at Penn State Health and medical director of a Hershey Outpatient Surgery Center. Her interests are ambulatory anesthesia and acute pain management, and obviously the biggest issue in which is the proper patient, the proper procedure, and the proper place. So she's going to talk about the proper patient. The proper place is Dr. Ehrman. Dr. Ehrman is the J. Jacoby Endowed Professor and Chair of Anesthesiology at The Ohio State University Wexner Medical Center. His interests are patient safety and outcomes, opioid use disorder, and respiratory monitoring, and he's going to talk about the emerging office-based anesthesia procedures. With the advent of the procedures, we now created an emergency manual, and that's going to be discussed by Dr. Brian Osman. He's a clinical associate professor of anesthesiology at University of Miami Miller School of Medicine. His interests are office-based anesthesia, orthopedic anesthesia, and acute pain and regional anesthesia. And he's going to talk about the 2025 ISOBIS OBA emergency manual. And Dr. Rajan is going to talk to us about the proper patient.
Thank you, Dr. Shapiro, for having me on this panel, and thank you all for being here. It's the end of the day, so I know. But I'll be talking about proper patient selection, selecting the proper patient for office-based anesthesia. So at the end of this presentation, how do you advance? Okay. So I'll be talking a little bit about evidence related to patient selection for office-based surgery, and then how to create customized patient selection criteria, and then decision algorithms for high-risk patients. I don't have any conflicts of interest. So I'll jump right in with this slide, and this is actually from one of Dr. Shapiro's studies. And these are a bunch of office-based publications on office-based surgeries looking specifically at safety and outcomes after office-based procedures. And this is a summary of what they found, basically. And you look at the various studies, the various sample sizes over the years, and you notice that mortality is not what we should be looking at after office-based surgery, because that is not an outcome that is of concern in an office-based setting. And a lot of the other studies say morbidity and mortality, but really in the office-based setting, we should be looking at other outcomes of interest, and that would be delayed discharge, unanticipated transfer to an emergency room, or return to operating room, or hospital admission. So this was kind of a summary of some of the outcomes that were looked at. And in this slide, back then, this was from 2014, these were the states and what they required that office-based facilities report to them as adverse outcomes. So this was back in 2014. Since then, more states have more requirements, but it's still not all states. So not all states have any requirements for office-based facilities to do any reporting of adverse outcomes to them. So some of the examples, I'm going to take my glasses, I can't see it. So some of the examples are unscheduled hospitalization, surgical site infection, death of a patient, or death of a patient day off or within 72 hours, transport of a patient to the ED, unscheduled admission. So these are the outcomes that states are requiring that office-based facilities report to them. So this is another slide that summarizes a large number of studies performed on outpatient surgery. So this is not in the office-based setting. This is ambulatory facilities. And they were all different types of studies. So there's prospective, retrospective studies with decent sample sizes. And again, they looked at readmissions, they looked at mortality, and they looked at complications. So the general trend is mortality is not gonna hit you, it's gonna be low. But readmissions and complications is what we should be looking at. So that is really the purpose of patient selection, is to avoid that patient that is likely to be readmitted or have a complication. So in the office-based setting, there are unique challenges that make gathering data difficult because not all states mandate any kind of reporting. Therefore, currently, there's only 33 states that require accreditation, and mandated reporting only 17 states. So the American College of Surgeons, in an effort to standardize care, published a statement calling for all office-based centers to be accredited by a national or state accrediting organization. So not all 50 states require even accreditation. So therefore, it's very, very important to select the proper patient for office-based setting. So this is again from Dr. Shapiro's study. All of the references are going to be from Dr. Shapiro. So the top 5 procedures performed in the office-based setting, based on a retrospective analysis of nearly 90,000 cases from a mobile anesthesia practice in New York. So colonoscopy, prostate biopsy, angioplasty, cystourethropy, and uterine fibroid embolism. So these were the top 5 procedures performed in the office-based setting. Now, I've put all these on the slide because all these organizations have something to say about patient selection in the office-based setting. So the American College of Surgeons statement mentions that physicians select patients for office-based procedures using the ASA physical status classification system, and anyone above ASA 3 should not have their surgery performed in the office-based setting, but should instead go to an ambulatory surgery center. So that's the ACS. The ASA statement says patients who have pre-existing medical or other conditions that put them at undue risk for complications should be referred to the appropriate facility. And Quad A actually has a very nice statement. But this is something interesting. I found Massachusetts Medical Society actually has these guidelines. They're from 94. They've had them as long as from 94. And this is what they said about office-based procedures. So they said each office should establish guidelines that describe criteria for determining patient selection. So it needs to be customized based on the facility, but they've put all these things that points to consider, which are really pertinent. So patient's medical status, including the severity of the disease state, the degree of stability of the medical status, psychological status, which is really important and not everybody considers that, support system at home, that's crucial to sending a patient home. And then they also talk about intensity and duration of post-procedure monitoring. So if someone's going to require prolonged monitoring, they're probably not a good candidate for the office-based setting, because unlike a surgery center where you have a PACU and a trained PACU nurse, you may not have that in the office-based setting. And then anyone who's at a risk of VTE, PE, really not a good candidate for office-based anesthesia. And then Quad A has standards. So these are the 2 standards dealing with patient selection. Any patient who, by risk of pre-existing or other medical conditions, is at significant risk should not have procedures in the office-based setting. And then they also say that the surgeon and the anesthesia provider should concur on the appropriateness of the patient, and then also check your state law to see if there's anything prohibiting certain ASA classifications from being done in the office-based setting. So the Quad A also says that facilities must have a policy and that all of this should be outlined in their policy as to how they select patients for the office-based setting, so for their particular setting. But they also say based on age, type of procedure, need for blood products, expected length of stay, and PACU. So that's really important. And then if the facility has the necessary medications and equipment, and they also put in, this is interesting, experience, ability, and skill of the team. So that's something to consider in the office-based setting. And then they want appropriate policies outlining all of these. So this is an interesting study. This team actually looked at comorbidities and tried to come up with a score that would predict the risk of unplanned admission after ambulatory surgery. And they gave each comorbidity a score, and then each type of procedure a score, and then based on the total, they tried to predict the unplanned admission probabilities. At the bottom, you can see. So it's interesting to note that the comorbidities that were highlighted were chronic pulmonary disease, diabetes, peripheral vascular disease, liver disease, congestive heart failure, depression, anemia, moderate or severe renal failure, drug abuse, or malignancy. And an interesting point about depression is, I was in the geriatric panel right before this. Depression is correlated with frailty. So depressed people tend to be less active. It correlates with frailty. So that's an interesting point to consider, considering how many people have the diagnosis of depression. So the recommendation is to avoid the following in the office-based setting. Potentially difficult airway, severe sleep apnea with multiple comorbidities, severe or exacerbated chronic pulmonary disease, recent MI within the past 6 months, recent stroke within the past 3 months, end-stage kidney or liver disease, severe anemia, sickle cell disease, and then any abnormal bleeding or clotting tendency, extremes of age, but then they don't go into detail. So again, I would say not just extremes of age, but you might have to do an assessment of frailty, which has a direct correlation with mortality. And then acute or chronic substance use, inability to cooperate due to severe anxiety and psychiatric problems, and then family history of MH is on there. Again, that's judgment-based. If an office is well-equipped and you're confident in the ability to manage someone, that's really up to the person. So I just put this in here for the clinical frailty scale to show that a lot of us are not very fit. A lot of us are probably 3 or 4 or even 5. So and then these are just some examples of risk assessment tools. I don't expect in the office-based setting that we'll be, assessing our patients based on these tools, but just to have an idea of they're out there, and just to keep that in the back of your head. This is an algorithm that I made for ambulatory surgery centers. I realize that not all office-based procedures would, fall under this, but you could do something similar with the surgeon's office so that when they go in for their surgical clinic visit, you could give surgeons some criteria based on which they would decide right off the bat that this person's not suitable for the office. And are they suitable or not suitable? So you could give the surgeon's offices some of these criteria so that you're not finding out about these patients at the last minute. So why do we do patient selection? What are we trying to determine? We're trying to determine if we're going to be able to perform a procedure on this patient at this location and at this time. So all 3 things. So if you're saying no, are you saying no to this patient? Or are you saying no to this location? Or are you saying come back another time to the same location, to the same patient. So those are the things you consider when you develop your criteria. And I wanted to put social considerations because that's crucial to a successful discharge, because our goal is to discharge the patient in a timely fashion and have them not come back. So health literacy, caregivers' ability to take care of the patient afterwards, do they have reliable transportation, and what are the living conditions when they go home? Are they going to be able to manage? So selecting the right patient is a dynamic interplay of procedure, patient, facility, and personnel factors. And the goal of patient screening is to identify where the patient falls among these four rectangles, and then develop appropriate customized screening tools. So I had some conundrums, but I don't think we'll have time. So, but I just wanted to put this here. This was a 66, this is a patient that came to my surgery center. So non-ischemic cardiomyopathy, EF of 15%, CAD medical management, systolic CHF, alcohol abuse, ED visit 2 weeks ago, 5 days sober, and wears a life vest. He doesn't want to get an ICD placed, so he's wearing a life. So I was just, would this be a good patient for your office? Sure. And then this was another patient that showed up. So he was told he's a difficult airway, but he's had vocal cord squamous cell carcinoma, but he's had it all dealt with, stable for 5 years. He has some OSA. I said he could come. He's going to be fine. So this was an interesting patient. So myasthenia gravis, anterior mediastinal mass, and uses non-invasive ventilation at night, but it's a carpal tunnel, so it's okay. Okay, so references, questions, please email me, and then come to Samba.
Thank you, Dr. Rajan. Our next speaker is Dr. Ehrman. First, we talked about the right patient. Now we're going to talk about the types of procedures that are happening in the office-based setting.
Excellent. Well, thanks, Dr. Shapiro. So my plan is to just give you kind of a high-level overview of sort of some of the newer literature and just focused on specific procedure types or specialties and some sort of recent data, if you will, some of the recent papers that have been published. And hopefully we'll have time for Q&A. So looking at trends and kind of newer office-based procedures, so ones that we've seen increasing in volume versus, say, ASCs or HOPDs, some safety outcomes, and future directions. We all know this. I call it the 3 Cs. There's different ways to look at sort of the allure of office-based practice, of course, but this is important when you're looking at specific procedures and trends. It's important to appreciate the 3 Cs, right? Convenience, comfort, and cost. Obviously, patients, they benefit from the convenience of, in familiar places, easy to get to, comfort, privacy, local places close to where they live, things like that. And of course, cost, that's a whole other conversation. But that's definitely a factor. Certainly reimbursements are driving a lot of these things as well as insurance for specific patients. So some of the sort of more up-to-date literature, and I know Dr. Rajan alluded to these 2 papers, but one is really just looking at kind of trends, right? Most common procedures in the office-based setting. Looking sort of old and new, and this is a nice table that separates them into different categories: ENT, plastics, GI, pain medicine procedures are obviously growing in this space, in the office-based space. Orthopedics, vascular is another area of significant growth. Plastics always has been, and of course, dental. And this paper that Dr. Shapiro and Osmond published recently, really just kind of trying to understand what's sort of the landscape like in terms of, again, the types of procedures being done in ASCs versus OBS, and sort of what the trends are looking like. So if you look at the top, again, this is a kind of a snapshot, right, of mobile anesthesia practice. They cover a lot of different sites. but just really thinking about what's being done in ASC, and that's a representative sample, I believe. Things like carpal tunnel, shoulder arthroscopies, things like that, more like ASC based versus, of course, no surprise colonoscopies, prostate biopsies, and angioplasties, immunographies were the top three for this particular practice. But, that's a lot of cases. So, again, just to kind of give you lay of the land, if you will. This is something, so we're celebrating 16 years of this particular checklist, and our safety initiative, Institute for Safety in Office-Based Surgery. But the point here, again, we're talking about procedure site, right? So we're talking about office-based location versus, say, ASC or HOPD or hospital-based, non-ambulatory. But this is a checklist that we created, and I kind of think of it more of it as of a template, right? So we work with other subspecialty societies and encourage them to adopt it to their specific setting, right? So if you're a plastic surgery office, an ophthalmology office, or radiology, or whatever that might be, and this is freely available, by the way, online, and really just for the purposes of my presentation, looking at the setting and things that you need to be sure about, EMS availability, for example, anticipated duration of the procedure, going back to the types of procedures, right? And then the surgery itself, and so on. So those are the 5 categories. I just wanted to introduce this, but it is freely available for you to even adopt it to your own clinical practice. This is a systematic review that I was part of, which I believe is still one of a kind, that actually looked at all what's out there in terms of patient outcomes with the focus on the type of facility, ASC versus office clinic, and basically looking at outcomes. Now, this was focused on specific procedures, OB/GYN related procedures, so this may not be applicable to all kinds of things. But really the question was for this systematic review, and I'll just say that a lot of it, all of them were pretty much based on retrospective studies, not prospective studies, really hard to do. But in terms of the effect of facility type, ASC versus office, again, the conclusion was really no difference in patient safety for outpatient procedures, looking at these 2 categories. Again, there's a lot of heterogeneity in the type of data, but again, this was the conclusion of our study, a systematic review. And we looked at specific outcomes as they were outlined in those papers. But again, there were significant, I acknowledge, limitations of those studies. But it's really hard, just by looking at the systematic review, to conclude that one site is per se safer, office versus ASC. Just a few recently published papers just to highlight some of the more recent developments in terms of the types of procedures being done, the outcomes, again, in the office-based setting that people are reporting. Lots of very interesting data from the plastic surgery specialty. They have a very robust way of keeping track of their cases. Their registry specifically focused on office-based procedures. So really helpful, to look at those, look at the data. Things that I highlighted. Again, we don't have time to go over all of these findings, but they did identify high-risk patients. They looked at types of complications, DVT obviously being some of the most common complications in the office-based setting for plastic surgeries. Again, this is more recent paper. There's another one as well related to this. They identified specifically high-risk patients in this population, higher BMI, higher operative times, taking a lot of lipoaspirate out, more than 3 liters, for example, and combined procedures. So really very robust data, I believe. And this is an update, again, pretty recent, again, looking at plastic surgery data. Again, abdominoplasty carries a risk of VTE, I'm sorry. And this newer procedure, buttock augmentation with autologous fat grafting, so that's becoming more popular. I guess the Brazilian butt lift carries a risk of fat embolisms, which is obviously different than the other type of embolism. So something that, again, because of this registry, they were able to highlight the risks of this procedure. An even more recent paper Again, no significant difference in adverse outcomes, again, looking at ASCs and OBS, and looking at commonly performed plastic surgery procedures. That's really the summary of this paper. Now, looking at dental procedures, obviously some of the most common procedures performed in the office-based setting. So this is a paper came from Ontario. One thing is, again, they have a large database. So again, one point to make is some of the subspecialty societies, and certainly ASA has their own registries, but we're not going to know about common complications, trends, more globally unless there are these registries that are properly maintained and they maintain high data integrity as well. And I think they certainly provide a lot of value. And so that we can, look at specific cases, look at the types of complications, risk factors, going back to patient selection, for example, and how to prevent certain morbidities, outcomes. So this is really just an example of this type of registry that they reported very, very low incidence of death out of 3.7 million, 3 deaths. And again, you're going to have to look at each and every one of them to see what actually happened. And of course, morbidity sort of complication rates were still pretty low. Endovascular procedures, so that's growing, as far as the number of procedures being done in the office. Endovascular Interventional Society National Registry, really, really helpful. So this came out, and again, I highlighted some of the major findings. Again, very low incidence of major adverse events, about 0.5%, and 30-day mortality had an N of 6, for example. And these are commonly performed procedures for indications such as claudication, minor tissue loss, rest pain, low extremities, and things like that. So very, very commonly performed procedures now in the office-based setting. So again, very low risk. So that's reassuring. And again, this is another paper looking at very similar procedures. Again, a very large number of procedures, very low risk. And again, they also looked at HOPDs versus ASCs versus office. And there was no significant difference in major complications, cardiovascular, pulmonary, or renal. So that's encouraging. Laryngopharyngeal procedures, right? So these are things like laser surgery, sort of minor things, biopsies, vocal cord injections. There's been obviously some high-profile cases with bad outcomes you all know about, at least one. But nonetheless, overall risk is pretty low. There's obviously a lot of it being driven by reimbursements and things like that. The other allure of doing this in the office-based setting is you can do a lot of these things under topical anesthesia, lower costs, whether it's for cosmetic reasons or for medical indication. So this is some of the newer papers that are coming out. Eye surgery, this is also very interesting. Again, one point here, very large registry. This is a European registry, almost 3 million cases. One interesting trend, and you probably, if you're in this business, wouldn't be surprised that topical anesthesia is increasing from 30% to 76% of the cases. More procedures are being done in the office in the United States as well. But there's also some interesting evidence, and that's what they said, that GA or doing a block actually can decrease risk of what we worry about the most is posterior capsule rupture, PCR, versus using a topical anesthetic. This is somewhat controversial, but at least this is what this paper suggests in terms of risk, right? Then there's convenience, reimbursements versus patient outcomes. So that's an interesting discussion. Certainly I'm having at my institution as well with, where should we perform these procedures into looking at reimbursements, but also looking at patient outcomes. So that's an interesting ongoing discussion. Urologic procedures, of course. Again, things like stents and sort of minor things, but nonetheless, pretty safe, excellent outcomes. Shorter procedure time, no difference in complication rates, interesting approaches, anesthetic approaches, either local anesthesia, using nitrous oxide. So that's something that our urology colleagues are very interested in. Obviously, we usually, you often don't participate in these, but nonetheless, nitrous oxide is something that there's a lot of interest in the urology community versus, GA and, involvement of an anesthesia provider. So that's really was focused on stents. GYN procedures, again, there are different options for a particular condition, right? You could either do a hysterectomy, of course, you wouldn't do that in the office, maybe in the future, or myomectomy versus a uterine artery embolization, UAE. And this is what this paper was all about. So really looking at minimally invasive procedures, endovascular treatments for these patients with uterine leiomyomas, right? And, looking at outcomes, looking at sort of, anesthetic options and things like that. So what they basically said on the bottom there, 75% of patients who underwent this minimally invasive embolization were discharged the same day. Obviously patients who had a bigger procedure, less, less of that in terms of same-day discharge and side effects and complications. So very interesting. So this is where we're going. This is where the world is going. So again, just giving you a lay of the land, kind of what's happening in different subspecialties, I think is really, really important. And this is really all I have. I do want to highlight, again, there's 6 facets to safety in the office-based setting. Dr. Shapiro and I published this short framework, if you will, that we outlined 6 important aspects, 6 Ps, if you will. The one that I addressed today, procedure in place. Of course, we talked about patient and policies and personnel and so on. So this paper is also freely available. That's really all I have. So thank you. Right on time, I think, almost. All right.
Thank you, Dr. Ehrman. Now, because of all these variety of complex procedures in the office-based setting, we created an emergency manual, and we updated the emergency manual, and Dr. Osman is going to share with us the information.
All right. Good afternoon, everybody. All right, I'll be continuing the series here on office-based anesthesia, emergencies, controversies, and cognitive aids. I'm doing the section on the update, actually, the 2025 update to the ISOBIS OBA emergency manual. Let's talk about why, okay? With the continued growth of office-based surgery, staff and practitioners really need to have access to critical information to be able to make, critical decisions during crisis management. Research is showing that the use of cognitive aids, especially tailored to the office, can really be effective in emergency situations and saves lives. So I realize I'm preaching to the choir here, and thank you guys for hanging out at the end of the day. A lot of you probably are familiar with ISOBIS, especially if you're interested in office-based practices. But this is something that was founded, it was a nonprofit organization founded by our esteemed Dr. Shapiro back in 2009. It's the Institute for Safety in Office-Based Surgery.
And Dr. Ehrman.
And Dr. Ehrman, of course. Yes, you are on the website. This organization is dedicated to developing, tools to promote safety, checklists, and educational resources for both health professionals and also patients, getting the patients involved as well to ensure safe outcomes during office-based procedures. This is an example of their homepage, isobis.org. You can see there are links here to the tools, the emergency manual, safety checklist, decision aids. These are things that can help you, not just the provider, but patients as well. All right, so let's move on to the manual. ISOBIS took a look at the most common emergencies that were specific to the office and published an emergency manual back in 2017, right? It's been that long. To give concise, user-friendly resources to the, treatments to these emergencies that can happen in the office. They're adapted from, widely based principles such as ACLS, MHouse, the Stanford Anesthesia Cognitive Aid Program, and also MGH. So they included 26 of the most common emergency scenarios in the office. As of 2018, this manual's been available on the Emergency Manuals Implementation Collaborative, or EMIC, and the website there is below. And you can actually see their webpage here. And now when I access this page, you can actually see the checklist at the top corner there. They actually had it on their homepage. But you can easily access it going to Tools and Resources, to Free Tools, and just scroll down and you'll find it. So since 2018, it's been pretty active in the literature. I mean, this has been popping up again and again. But things have changed, right? Life is very different now than it was in 2018. So let's think about this. This is when France won the World Cup. These two got married. I don't even want to talk about that. Elon Musk decided to launch a Tesla Roadster into space. This was the release of the iPhone 10. I think we're on the 17 now, right? And that was the year that Voyager 2 actually passed through the heliopause. So that's officially when it entered deep space. It only took 42 years. Of note, the RAM memory on this thing was only about 70 kilobytes. So this thing has 12 gigabytes, so it's about 12 million times the processing power of the satellite that's now hurtling into deep space. But office-based anesthesia has also changed dramatically in the last 5 years. We've seen an increased volume of cases. There are more complex patients, more complex procedures presenting. And of course, with that, there are new emergencies and adverse events to consider. So how has office-based anesthesia changed? The metrics are a little difficult to quantify, but if you look at the outpatient procedures from 2018, there were 129 million cases, then and increased to 144 million cases in 2023. So as part of this trend, you would expect the office-based procedures to increase as well, and they have. And why is that? Convenience for one, easier scheduling, less non-operative time, greater perceived privacy than compared to a hospital. It's cheaper, right? You have significant cost reductions compared to the hospital-based procedures, incentivized by the payers, including Medicare. In fact, CMS pretty recently removed the inpatient-only indication for hip and knee replacements. So a lot of these are moving now to the outpatient setting. These procedures are being successfully done in ASCs. There's been plenty of advancements in medicine, right? Anesthetic techniques are getting better. There's less invasive surgical options, less painful, smaller cuts, robotic procedures, and it's a little hard to put a robot in an office, but just in general, the technology is getting better. And ERAS protocols that we're using on a daily basis are making it easier to get patients out same day. And then, believe it or not, there's still residual effects from the COVID-19 pandemic. And this was a time where people just absolutely did not want to be in the hospital. Restrictions on elective surgical procedures, they accelerated the push towards the office care. It's a trend that's still going on today. Now, this was a publication from 2018 predicting to 2025. We're currently in 2025. If you take out that blip there for the global pandemic, you can see that the OP, or office procedures, were sort of outpacing things in terms of increasing in numbers as of 2025 when compared to inpatient tertiary procedures, outpatient, inpatient, and emergency. And the next 5 years are predicted to increase even further. So what does that mean? You have more patients coming, more procedures, more complexity. You're going to start seeing sicker patients. Now, we talked about this already, trying to avoid certain conditions, but unfortunately, this kind of comes on a gradient. There's gray areas, right? You can't put them in one pile or another because there's certain, some people have a little CHF, some people are, more abundant with CHF. So, there's congestive heart failure, atrial fibrillation, whether or not it's controlled, advanced kidney or liver disease, uncontrolled hypertension, diabetes, COPD. These are all things that have to be considered. Also, these implantable devices coming in, pacemakers, ICDs, or both, right? We have GLP-1 receptor agonists, SGLT2 inhibitors. The use of these have skyrocketed for diabetes. It's been very effective, and also for elective weight loss, also for health. New specialties are starting to enter the office. We have several publications talking about that. And new procedures are starting to, introduce a unique set of risks. Now, Dr. Ehrman already talked about the gluteal fat grafting, AKA Brazilian butt lift, BBL. This stuff is all over the news, you know, especially in Florida where I'm from. You know, you read about cases going south, people dying on the table, people going to some sort of step-down facility and then dying there because of some sort of perioperative, I would say, fat emboli occurring. And studies have looked at this in 2017, a little while back. There were almost 200,000 cases in this study. They showed 135 incidences of a fat embolus resulting in 32 deaths. Just 2 years later, another study claimed that the BBL had the highest death rate compared to any other procedure. And that was 1 death in 3,348 patients versus 1 death in 55,000 patients that were undergoing general anesthesia for non-cardiac surgery. So these numbers speak for themselves. All right, in the last 5 years, we've definitely had a tsunami of these GLP-1 agonists introduced into the field. It seems like everyone is on them these days. The perioperative management recommendation for this keeps changing, especially in the last few years. It's frequently updated by the ASA. Obviously, our biggest concern is going to be aspiration. It's interesting because originally it was to consider stopping the drug for 1 week before the procedure, but now it's really more, hey, you know, are they having symptoms? Do they feel like they're having dyspepsia, nausea and vomiting day of surgery? They're even, you know, moving towards the recommendation that you don't need to stop these drugs. But let's talk about in general, right? Pulmonary aspirin rates are about 1 in 900 to 1 in 10,000 cases of general anesthetics. This is not, you know, this is not negligible. I mean, this happens. More importantly, the rates in the office setting are limited. We just don't have the numbers. It would be prudent to consider these patients full stomach. If you do decide to proceed under the current guidelines, it's important to have the rescue equipment. You know, do you have suction available? Do you have a difficult airway cart? You know, a way to manage this. And certainly we've addressed that with the update to the emergency manual. SGLT2 are sodium glucose cotransporter 2 inhibitors. There's a big concern for euglycemic ketoacidosis. This is challenging because there's no clear diagnostic criteria to sort of differentiate the different types of ketoacidosis. So you can't exactly get the incidence or impact. Therefore, we can't get evidence-based studies on this or appropriate guidelines. There's variable recommendations. And again, when you get to the office-based setting, the recommendations are even more limited. Now, I did find some guidelines. Everyone is pretty familiar with the idea of holding this drug for 3 days or their cousins. I think if you see there there's one that's there for 4 days if you look on the STAR drug. Once you get inside of 3 days or for these exceptions, things start to get muddy and you can see how complicated things get. Well, in the last 5 years, workplace violence is something that has really been an issue, and I'm not just talking about active shooting issues. This was an active shooting event that took place at a VA outpatient center in Florida. Thankfully, nobody was hurt. But outside of that, for every 100,000 full-time workers, there's about 14.2 cases of workplace violence. Studies show that in Massachusetts, a healthcare worker is physically assaulted, verbally abused, or threatened every 38 minutes. I don't know if you can corroborate that. 6% of this actually happens in the outpatient setting. There's two big issues here. One of them is that offices may not have the personnel. You may not have a security guard or a police officer that's on site to be able to mitigate or de-escalate these things. But even more importantly, a pretty recent analysis of 18 studies showed that outpatient workers just don't get any kind of training for this. You know, they don't know how to deal with it, and that's significant. All right, cardiac implantable electronic device is kind of a wastebasket word. I mean, you're talking about ICDs, you're talking about pacemakers and combinations of these. The issue with this is that, again, in the office, you don't have a reliable number of how often these things fail. And if somebody's pacemaker dependent or they get into a lethal arrhythmia, you can really get into trouble quickly if you're not prepared to deal with it. In general, okay, we're going back to that, the general malfunction rate is 0.4%. Lead failure can happen in 2.3 to 5% of cases. And really, it's just a matter of not having the equipment or training to be able to deal with sudden failure due to either electrocautery interference or intrinsic device issues. So that's another thing that appears in the manual, that update. All right, postoperative airway problem. The most famous, Joan Rivers, very unfortunate case, severe laryngospasm. And, you know, the details of this are muddy, but whether or not they were equipped to deal with this is sort of, nobody knows. However, time is of the essence, right? You have 2 minutes to figure it out before somebody gets anoxic. Basically, it can be catastrophic if you're not able to deal with these emergencies immediately. And these emergencies are expected to increase, right? You have a higher number of patients, laryngospasm, anaphylaxis, angioedema, and obesity. I don't need to labor on the numbers here, but it may seem small, but as you increase the numbers of cases entering the office, the likelihood of this happening to you is more, probable, and you need to be on your toes. Because 2 minutes, that's it. 2 minutes feels like an eternity, but the brain thinks otherwise. Obesity, hard to say. I mean, everyone's on Ozempic nowadays, so there's pretty significant weight loss, but you still have the general issues of losing the airway, problems with ventilation, difficult mask, difficult intubation, postoperative respiratory failure, either from anesthesia, opioids, or a combination. And of course, aspiration, right? We talked about that. Do you have the appropriate equipment? Is there difficult airway carts? Do you have an algorithm to deal with this? Well, that's why we stepped in, right? All right, I'm out of time and just on time. So this is basically the table of contents, including the updates. The updates are highlighted. The one thing that I didn't cover is mental status change. I do have the actual chapters here that were added. It's workplace violence, embolism, pulmonary fat. Mental status change, obviously, the things that you want to do is respond immediately and try to find the reversible causes. Do something like a stroke assessment, fire off some, relevant labs if you have access to that. And, if things aren't improving, go down the emergency pathway. And these are just examples here of the chapters that we've included. And that is it. Thank you.
Excellent.
Thank you, Dr. Osman. Now I'm going to talk about office-based anesthesia of the future. And, I'm calling this technology, simulation, and AI anesthesia for the next generation, but I think we should really call it human algorithms versus AI algorithms. We already talked about the Institute of Safety and Office-Based Surgery, which Rich and I created 16 years ago. I'm going to talk a little bit about AI, technology and simulation, and AI, which is a grant we got from the Anesthesia Patient Safety Foundation, which talks about algorithms and algorithms. And also talk to you a little bit about my future research in Boston on closed-loop anesthesia delivery system. And then I'm going to paint you a picture of what I think that office-based anesthesia is going to look like in 2050. So just to, start from basics to get everybody on the same page, for artificial intelligence, we all use it. I mean, these are some areas that we all use all the time, but we don't realize that we're using artificial intelligence. The way it's defined is, broadly defined, as ability of a computer or device to analyze a large volume of complex healthcare data, reveal knowledge, identify risks and opportunities, and support improved decision-making. Now, there's 3 types of AI within the large terminology of artificial intelligence. There's machine learning, which teaches patterns of large amount of data to build classification and prediction models. For example, post-induction hypotension, prediction of postoperative in-hospital mortality. And there's deep learning, which is multiple layers of neural networks to progressively extract high-level features from raw input. So they're trying to create similar to the human brain. So if you do this, you can look at facial structures regarding facial and neck images to look at difficult airways and cardiac structures during an echocardiogram. And then there's natural language processing, which extracts relevant information from spoken or written content. So this is good because it can predict ICD-10 diagnosis codes versus having people manually code it, and automated creation of pre-anesthetic evaluation. So let me share with you a little bit about our grant and what we did, what we published, and where we're going in the future. So we created the idea of a smart assistant and basically it is a real-time dual interactive decision support in the perioperative period. And basically it has involved the APSF human workflow during perioperative deterioration, making technology meaningful and integrating anticipation for planned deterioration. So what our aim was to design a pilot study that uses real-time audio and visual questions to provide interactive decision support. The hypothesis was that the smart assistant will aid decisions in making quicker and more effective decisions. So think of it as a Siri or Alexa in one of your ears or Google Glass. So what we did was we compared the present standard of care and clinician decision-making in simulation scenarios in terms of physiologic deterioration versus enhanced capability with the audio and visual questions. So what the smart assistant was is using artificial intelligence, using pattern recognition, physiologic data, plus the patient's medical history. That could create a differential diagnosis coupled with the best practices and the emergency cognitive aids. So those using artificial intelligence algorithms, using emergency checklists and cognitive aids, that's human brain algorithms. So this could be customized to provider need or the clinical situation, whether it's an OR, ICU, ambulatory surgery center, or an office. The system could be integrated into the electronic medical record. So again, think of it as the Google Glass or Siri or Alexa. And the reason why is the clinician could capture data with all the senses and not taking their eyes off the patient. So what did we find? We did this study with anesthesiologists and nurse anesthetists. My colleague Stephen Greenberg did it at Endeavor Health in Chicago. And we did a prospective randomized controlled pilot simulation study to investigate the effect of audio-visual decision support on diagnosis and therapeutic interventions. 20 anesthesiology professionals, and nurse anesthetists and anesthesiologists, 3 peri-procedural scenarios: anaphylaxis, amniotic fluid embolism, and cardiac arrest during the pediatric dental case. What they found in Chicago was a statistically significant decrease in the time to diagnosis in amniotic fluid embolism and pediatric dental scenarios. And also a survey of the people that were in the study showed that there was a desirability of the audio-visual decision support amongst anesthesia professionals, but there was no significant difference in the time to intervention between the groups of all simulation scenarios. Now, we took this one step further at MGH in the Learning Center. So what we did was we did it with anesthesia trainees. So we had student nurse anesthetists and anesthesia residents, and we created the cognitive aids, and we created the Siri or Alexa, so we had a deep voice from the control center. So as you can see, let me show you here, you can see the cognitive aids, but this was what the person who had the smart assistant would see, and you can see this is the control center. When we aggregated the data between Endeavor Health and MGH, we found a significant improvement, statistically significant improvement in the anesthesia professional and trainee pooled median time for correct diagnosis and for amniotic fluid embolism and the pediatric dental case. Again, there was no significance in terms of the time to treatment. I want to switch gears a little bit because we're talking about office-based anesthesia. So let me share with you what we know, and then I'm going to share with you studies have shown how we can improve what we already do. Now, this was a closed claims analysis by Dr. Ehrman and Dr. Karen Domino. I believe they did this in 2017. So this came from the National Anesthesia Clinical Outcomes Registries. They looked at GI endoscopy procedures were 17% of the cases. GI endoscopy was the majority of the NORA malpractice claims. Monitored anesthesia care comprised 89% of the claims. Inadequate oxygenation and ventilation were 30% of the claims. And the malpractice claims were a higher proportion of claims for death versus the OR. This basically shares that death was more significant for the Nora claims, and a MAC was the type of anesthesia. Respiratory events were the most common cause, and they were preventable by monitoring. Now, a recent closed claims analysis, I believe Dr. Ehrman did this again, and what they found that malpractice claims were relatively low for Nora, but there was a higher incidence versus OR case in OR airway management, respiratory depression, inadequate ventilation, and aspiration, which is consistent what we've discussed for the panel. And the recommendation was preoperative screening, emergency preparedness, that's the creation of the manual, and utilization of advanced airway management, implementing checklists, interdisciplinary communication, and improved provider training is essential. So this is what we know today. This is the updated literature from 2025. So now the question is, how can AI help us make it safer? Let me give you examples of some articles that can come out that can address these issues of GI endoscopy, inadequate ventilation, and oxygenation in MAC cases. So this is an interesting article. So this is dynamic prediction of hypoxemia risk at different time points based on preoperative and intraoperative features. So this is a machine learning application of outpatients undergoing EGD procedures. So they looked at 1,160 patients between 21 and 22 undergoing EGD and Nora. 112 developed intraoperative hypoxemia, 102 developed during induction period. The area under the curve was 0.93 to 0.95 of this machine learning application, and the predictive performance of the AI outperformed the stop-bang score. Now, the model, they said, was an excellent predictive ability integrating clinical indicators. What were the clinical indicators? Preoperatively, they looked at airway assessment, SpO2, and BMI. And an interesting finding that they found, of those 102 patients that developed hypoxemia during induction using these machine learning applications, those with the induced propofol dose made a difference. So they looked at the induced propofol dose, and that was one of the indicators. Now, as you can see, Dr. Ehrman talked about the different procedures, and Dr. Osmond talked about the GLP and SGL2, and they addressed this in the closed claims analysis about aspiration. So here's another machine learning algorithm. It's created, this was creating a simple risk scoring system for predicting the occurrence of aspiration after gastric endoscopic submucosal dissection. Now, these are longer procedures, and they wanted to investigate the risk factors and develop the scoring system to predict aspiration pneumonia. 7,800 patients undergoing EGD were reviewed by reviewed for gastric neoplasm under anesthesiologist-directed sedations, and these, again, were longer procedures. The incidence of aspiration, 1.5%, the top factors in a multivariate logistic regression model, and they created scores from 0 to 33, and the aspiration probability was 0.1 to 18%. And these were the 8 top predictive factors, and area under the curve was 0.73. Age, as you can see, sex, BMI, procedure time, these were greater than 80 minutes, lesion in the lower third of the stomach, tumor size greater than 10 millimeters, recovery time greater than 35 minutes, and desaturation during the EGD. Now, Dr. Rajan talked about proper patient selection. So here's a machine learning study to predict suitability for surgery at an ambulatory surgery center. So this was a site optimization model that created machine learning to stratify patients on patient suitability and the likelihood of performing the surgery at an ASC. Now, follow me with this. There were 2 components of the model: a review review component that would be that the prediction that the clinician would review whether the patient was suitable for the ASC, and then the location. That means the surgery should be done at an ASC. So how did they create the model? It was trained. The model was trained using 30,000 historical clinical reviews, using features from Epic based on institutional anesthesia guidelines for ASC suitability. Now, this was just one institution, so this is going to change with different institutions. But the features that they looked at were age, sex, the vital signs, BMI, BP, the HbA1c, creatinine, the diagnosis, surgical procedure, whether the surgeon requested the ASC. Now, you have to understand the benefit of using machine learning is it basically, if you have people that are using manual review, it's labor intensive. So basically, the patients that are obvious for the ASC and the patients that are not, that are obvious for the hospital, are the ones you really don't need. The ones that are most important with human review are the mismatches, the shades of gray, as you will. So AI-assisted reviews were more efficient. They save 80 hours a week and 2 full-time employees. Just to review this in a chart, so you have the surgeon requesting a case. You have the review model and the location model. The prediction that that's the predicted probability that the clinician will review and say the patient is suitable for ambulatory surgery. And that's the AOC is 0.846 with a 95 CI. And there's a location model. So the predicted probability that the surgery will be done in an ASC. And you can see there's six divides this into 6 categories. So this is clearly patients, when the surgeon requests a hospital, and these patients clearly should be done in the hospital, and then the surgeon is requesting an ASC, and they're clearly patients that should be in the ASC, and then there's likely hospital and unclear and likely ASC unclear. The unclear ones are the ones where I think the point is that the human review might be better. But there's limitations with AI, so it's not perfect. It's a black box, results lack clinical explanation. AI will provide prediction, but it will not provide further reasoning why the prediction was made. Obviously, like I shared with you, you have implicit and explicit bias in the data because the data has to be from not just one population. It has to be from all population to avoid healthcare disparities. And it's imperative for clinicians to communicate with data scientists for appropriate interpretation of data analysis. AI excels in identifying patterns and showing correlations but cannot determine the cause. Lack of proper validation and standardization. And if there's a misdiagnosis by AI, who's legally responsible? And then there's security concerns, the need to prevent data breaches that could expose sensitive information. There was an interesting article that came out in Anesthesiology in 2020, and it says AI in anesthesiology. What are the techniques, clinical applications, and limitations? Well, I'm going to talk about the third one. AI could provide anesthesiologists with expertise with decision support, similar to the smart assistant that I described to you. Now, there were another issue where genetic markers response to specific therapies as uncovering markers for drug selection, dosing, adverse events like personalized medicine. And then I want to talk to you lastly about control systems, the closed-loop anesthesia delivery systems coupled with AI. But the fact is that human brain can extrapolate the known to unknown based on scientific phenomenon. AI can only draw conclusions from the data that you feed it and data seen and analyzed. So just to finalize this and close, the closed-loop anesthesia delivery has been, it's not FDA approved, but it's been shown to reliably and accurately control real-time unconsciousness maintained by anesthesia in non-human primates. The study that we're going to do basically, now follow with me here. Now this is a targeted controlled infusion. I'm going to put this over here so it goes on the screen for education purposes. Let me see, I can do this. Okay, so you have a targeted controlled infusion, and then you I'm going to be right here where you have the patient. The patient is wearing a monitor on their brain that's looking at the compressed spectral EEG analysis. So you have the marker of unconsciousness from the patient. And then you have the target, which is at the receptor level, and you have a linear quadratic integral controller. And that is based on the targeted controlled infusion. So basically, you have the marker of unconsciousness, you have the closed-loop system continually administers propofol to control unconsciousness, and the linear quadratic integral controller calculates the difference between the estimated and the target marker of unconsciousness, changing the infusion rate. In each cycle, the marker of unconsciousness is updated from the local field potential. Now, I know this sounds complicated, but we've seen robotic surgery, and then this is what you're going to see in robotic anesthesia in the future. This article came out recently about anesthesia in 2050, a better anesthesia. So basically, how can anesthesiologist AI improve perioperative outcomes? So this was the infographic on the cover. But basically, in summary, a few of the things we mentioned. Preoperatively, you can use it to look at ICD diagnosis. Decision support systems can assimilate patient data for patient care, which I described to you in the APSF grant. Intraoperative, like I showed you with the machine learning algorithms regarding hypotension, hypoxia, uterine output, predict acute kidney injury. And I described to you the closed loop anesthesia delivery system, precise titration reduction of propofol. And postoperatively, it can predict binary events like readmission and mortality. And lastly, my students that, say to me, Dr. Shapiro, we don't give out cards anymore. We're going to make you a QR code. So if you want to see what Dr. Ehrman and I are doing, we just ISOBIS is supporting a scholarship for an office-based anesthesia mentor-mentee program that's affiliated with Samba, that's endorsed. So you can see what we're doing. It's free. And then I invite you to our annual meeting in Washington, D.C., the 13th and 16th. As I said, I'll be becoming the president, and I'm very pleased to entertain any questions. Thank you very much.
All right. Let me have people come up because